for the invitation to your nice event in the unique region. I would like to speak about the PE management in year 2025, because the use of catheter-based treatment has increased during the last year, especially the mechanical thrombectomy being adopted due to ability to achieve very early hemodynamic improvement without the thrombolytic agent. But this rise in adoption unmet the proper evidence until now, because now we have the result from the STORM-PE clinical trial, and it's the first randomized clinical trial which comparing the mechanical thrombectomy plus anticoagulation to anticoagulation alone, because until now the evidence was mostly observational or retrospective. And so this is the reason why the STORM-PE is so important, because the endovascular therapy for the treatment of PE, we know about this more than one decade, but the position of this treatment in the guidelines are still unclear due to lack of good evidence. So now we are very happy that we have the results from the STORM-PE clinical trial, because this is the first completed RCT in this time more than one decade. In this clinical trial was very important the primary endpoint. The primary endpoint was the RV-LV ratio, because this is the very good predictor of mortality, PE-related, and also the short-term mortality in patients with PE, because increased twofold the risk of early death, and in patient in PE there is the increase more than 3 times. And for what is very important for this clinical endpoint is that very small changes in RV-LV ratio leads to better outcome for the patient with the acute PE. This is the very important, because the right ventricle is adapted for the preload increasing, not for the afterload increasing. This afterload increasing leads to the dilatation of the right ventricle, D-shaping of the left ventricle, and left ventricle diastolic dysfunction. And this is the very bad outcome for our patients. So the primary efficacy endpoint was the change in this RV-LV ratio in 48 hours. And this was superiority of computer-assisted vacuum treatment against the anticoagulation treatment alone. The inclusion criteria was the acute PE in intermediate high risk with RV-LV ratio more than 1 on CTPA, and patient with high hemodynamic instability or on ECMO or new score more than 9 were excluded from this trial. The procedural information and the details from this study: the thrombectomy time was 25 minutes. It's similar like in real life from the Strike PE registry. Procedural time was less than 1 hour, and in this clinical trial using the CAVT, there was the very low blood loss in all patients, and technical success was 100% in the patients in this clinical trial. The primary efficacy endpoint, this RV-LV ratio, was superior. There was superior reduction in the arm with CAVT. If we look on the clinical data, there was a relative reduction in arm with CAVT up to 30% versus to 13% in patients only with the anticoagulation therapy. And what was also very important, that absolute reduction, not only relative reduction, was highly significant in patients after the CAVT due to pulmonary embolism. The secondary safety endpoints was similar between the arm with CAVT and anticoagulation treatment alone. There was comparable 90-day safety rates. There was no device-related mortality, no procedure-related mortality, and no PE-related mortality in more than 7 days. In the safety event details, there was documented two deaths. One was due to cardiac arrest during the DAVT thrombectomy using non-CAVT device in 5 days, and the second was the cardiac arrest from the hemoptysis during the index procedure, but no pathological evidence of vascular injury, so it was not device or procedure related. For this hemoptysis, there is very common in these patients, and it's not still related to the procedure. It's not related to the device or the wire. It's very common after the reperfusion of ischemic pulmonary segments, or also after the reperfusion when the bronchial pulmonary shunts are open, and this could lead to this hemoptysis without the relation to procedure or to the device. In patients after the CAVT procedure, there was a significant decrease in heart rate and tachycardia in 48 hours, and this is it's consistent with improvement of RV output, and also the decreasing of the sympathetic drive. And also the oxygen demand was lower in patients after the CAVT arm in 48 hours. It was due to improving of ventilation and perfusion ventilation mechanism in patients after the CAVT procedure. And also there was the functional endpoint, because the 6-minute walk test was much more better than patients after the CAVT procedure than in the patients in the anticoagulation treatment alone, because the change between the 13th and the 19th days was up to half, and it was the change 37 meters. It looks not so much, but if we look on, for example, to the trial with tricuspid TEER, for example, Triluminate clinical trial, there was the change for the 6-minute walking test in the patients after the successful tricuspid treatment, only 25 meters in 1 year. And here in this study, we had 37 meters in 60 days. So in conclusion, the STORM-PE is the first RCT which compares the mechanical thrombectomy with anticoagulation therapy versus the anticoagulation therapy alone. And this CAVT demonstrates superior reduction in RV dilatation with the similar safety profile to anticoagulation therapy alone. And when we look on these results, the mechanical thrombectomy with the CAVT device, it's very safe procedure, and we have the internal validation from this STORM-PE clinical trial, but also we have the big registry, the STRIKE-PE registry with more than 1,500 patients, where the results now are same like in this STORM-PE. So now we have validation from the internal and the external point of view in a patient with intermediate high-risk PE, which are treated by CAVT. So when we look on this data, why do we need the PERT in light of this data? Because this is the concept which was the previous. We had the chaos in treatment of the patients with the severe PE. Now, according also to our current guidelines, we are established some PERT team, and this PERT team disappear this cause in treatment of the patient with the intermediate high or high risk PE. This is the most recent guidelines on international treatment of on PE. This is from this year, and we clearly see that the PERT team play a very important role in the decision making in the strategy of treatment of PE in our patients. And what is also very important, according to European consensus for the mechanical thrombectomy in patients with the PE, that after the systemic thrombolysis, if there is no hemodynamic improvement after the 2 to 4 hours, there is this still space for the mechanical thrombectomy in these patients, and we have very good experience with the CAVT in these patients after the failed systemic thrombolysis. So thank you very much.